Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bridge Bio.
This program is presented by Medscape Education Global.
Hello, I'm Sarah Cuddy from the Brigham and Women's Hospital and Harvard Medical School in Boston. Welcome to this program titled Unpacking New Data from 2024 Congresses on Transthyretin Amyloid Cardiomyopathy. Joined by me today, I have Mariana Fontana, Professor of Cardiology at the University College London in the United Kingdom, and Dan Judge, Professor of Cardiology at the Medical University of South Carolina. Today we are going to discuss the latest clinical trials evaluating new and emerging therapies for ATTR cardiomyopathy and the implications for future clinical practice, which patients may benefit from new treatments, and the evolving therapeutic landscape. How might future approvals of emerging agents impact our clinical practice? So a brief introduction. Transthyretin amyloidosis, known as ATTR, is a form of systemic amyloidosis where the TTR protein misfolds and aggregates as amyloid fibrils that infiltrate, in the case of cardiomyopathy, the heart. The commonest form is wild type. This is a spontaneous condition that is associated with age and predominantly has a cardiac phenotype. There is also a variant form due to a single point mutation in the TTR gene, with over 120 different mutations in the gene recognized. This can cause either a predominantly cardiac or neurologic or mixed phenotype. And today our focus is on the treatments that address the cardiac phenotype. This disease was considered rare, but now we're realizing the prevalence is relatively common depending on the population studied. And really what has driven the field forward is these new effective therapies. So what we predominantly have been trying to target is that TTR protein, either by stabilizing the protein to stop it from breaking down and forming the amyloid, or from targeting its production at the level of the liver. And we're going to discuss these various trials that have looked at the agents in this conversation today. So the initial therapy approved for ATTR cardiomyopathy was tafamidis, which was based on the ATTRACT study that was published back in 2018. We'll review some data from that study and its long-term extension, and many others that have been published or presented since. So let's take a closer look at the recent key clinical trial updates for new and emerging therapies in ATTR cardiomyopathy. First of all, Mariana, you presented the HELIOS-B data at the ESC this year, and are the first author on the paper that was detailing the outcomes of this phase 3 clinical trial. So I'd love for you to summarize the findings of this trial for us.
Thank you so much, Sarah, and it was really my pleasure to present on behalf of all co-authors the results of the HELIOS-B trial at the ESC. So the ESC trial is a trial which recruited 655 patients with hereditary or wild-type ATTR cardiomyopathy, and the patients were randomized 1-to-1 to placebo or vutrisiran, which was given by a subcutaneous injection every 3 months, so 4 times a year. So within the trial there were 2 pre-specified populations, so the overall population, which included every patient, and the monotherapy population, which included the patients who were not on tafamidis at baseline. So patients were randomized 1-to-1 in a double-blind period up to 36 months, and at the end of double-blind they were eligible to enter the open-label extension where every patient was receiving the active drug. The primary endpoint was a composite all-cause mortality and recurrent cardiovascular events, and then there were 4 key secondary endpoints, which was a change from baseline, the 6-minute walking test, in the KCCQ, all-cause mortality, and NYHA class. What's important to bear in mind is that both the primary and the secondary endpoints were tested in the overall population, but also in the monotherapy population. So there was a total of 2 primary and 8 secondary endpoints. And what was remarkable about the trial is that the trial met all the 10 endpoints, the 2 primary and the 8 secondary, so in the overall population, but also in the monotherapy population. And so there was a very deep reduction, a 28% reduction in the first composite endpoints, so all-cause mortality and cardiovascular-related hospitalization, and this was in the overall population. But importantly, when also all-cause mortality was looked at in isolation, and all-cause mortality was looked up by adding up to 6 months of the open-label extension data, also the trial met the overall mortality. And so why those extra months were added? And this was really to increase the number of events and increase the precision of the overall estimate. And so vutrisiran achieved a 36% reduction in all-cause mortality through the 42 months in the overall population. And, but also the trial had, within the secondary endpoints that really matters to patients, similar to other trials, which was functional capacity as measured by the 6-minute walking test, quality of life as measured by the KCCQ, and then changes in NYHA class. And so, and when the 6-minute walking test and the KCCQ were looked at, on kind of the observed value, so without imputing for missing value in patients who were dying or unable to walk because they are progressing too fast, there was a relative stability on the vutrisiran arm as compared to placebo. So in keeping with the high degree of stabilization seen in this contemporaneous population with mild disease compared to previous trial, but also in a population where there was a heavy use of background medications, including tafamidis, 40% baseline, and SGLT2 inhibitor.
Thank you very much for that great roundup of the data that you presented at the ESC. And I wanted to ask you, can you comment on any of the patient subpopulations and further on any of the biomarker data that fascinated you the most?
Absolutely. So what was important for this trial, but also I think it recapitulates in many ways our experience with drugs which reduce the new amyloid production, is that there was greater benefit in early disease. So in patients who are younger, 75-year-old, less than 75-year-old, and with an NT-proBNP less than 2,000 nanogram per liter. And so on this patient, there was a 46 and 48% reduction in the primary composite endpoints, overall mortality and recurrent cardiovascular events, and a 45 and 65% reduction in all-cause mortality, respectively. And these really, for us as clinicians working in the field, have really strengthened the importance of early diagnosis. So we need to be aware of the disease to do the appropriate tests and identify patients early, because the earlier we start this treatment, the greater benefit the patients are going to receive. So the second subpopulation, which was very important, was patients on and off tafamidis, because there were a lot of questions on the added benefit of gene silencers on top of tafamidis. And what we saw is that there was no heterogeneity of treatment effect in patients on and off tafamidis, meaning that there was no evidence of attenuation of the treatment effect, in keeping with a possible added benefit of a gene silencer vutrisiran on top of the tafamidis. There was also important data that were presented very recently on the changes in structure and function by echocardiography. So every patient received echocardiography throughout the study, and deformation and non-deformation parameters, base parameters, were assessed in everyone. And so what was meaningful for me looking at those imaging data was the consistency of the results across structure, systolic and diastolic function. And also it was very interesting for me the order in time of those changes, in the sense that was the diastolic function was the earliest to change. And actually on diastolic function it wasn't just delaying disease progression, but actually on the E over E prime there was evidence of improvement in the diastolic function. Then there was evidence of changes in systolic function. Here was delaying disease progression and then changes in structure. So for me, it was the consistency of the treatment effect across systolic, diastolic function and structure, but also the time to onset the treatment effect, which is exactly what we would expect, i.e. diastole getting affected first, and systole, and then also changes in structure. And I mean, to my surprise, but I mean, a positive surprise was actually the improvement in the diastolic function. So not just about delaying the disease progression, but actually bringing about improvement.
Yeah, really great data, and really see it kind of that it reflects kind of what we know about pathophysiology in the disease with these echo findings of structure and function. I don't know if you want to comment further on the NT-proBNP changes.
Absolutely. So in terms of blood biomarkers, we use the NT-proBNP and troponin as important markers because we know that they have got a very strong prognostic significance at baseline, but now we know that actually also changes over time can be used in patients to track disease progression, and now we have got thresholds that can be used. And what we saw very clearly on the NT-proBNP was a favorable effect of vutrisiran on the NT-proBNP versus placebo. And this was there as early as 6 months. And 32% relative reduction at month 30 in the overall population. So this also gives us very important information for the clinical settings. As early as 6 months, we could measure an NT-proBNP and actually assess like improvement or stabilization in the patients. Also in the troponin I, there were a favorable effect of vutrisiran on troponin I versus placebo. And again, these were seen as early as 6 months. So 6 months seems to be a very important time point that we should keep in mind when reassessing the patients, with a 32% relative reduction month 30, again in the overall population.
Yeah, it's really nice that we potentially have these biomarkers that we'll be able to use for tracking response to therapy, and as you say, as early as 6 months into a new therapy. So Dan, I'd like to ask you your impression of this data.
Well, so first, it's an amazing trial, and the nice thing about it is vutrisiran's been around for a while for hereditary TTR polyneuropathy. So we know it's safe, we know it's effective, and I'm really glad to see that it works for cardiomyopathy, but I'm not surprised. I think the one thing that stands out for me, and Mariana touched on that a little bit, is the ability to discern a difference between treatment with an oral stabilizer versus a silencer, with vutrisiran versus tafamidis. And I understand that 40% of the patients were on tafamidis, so not as large a number as we might be able to do a meaningful comparison head-to-head, but that's the one thing I would love to see, is a meaningful comparison between the two or the additive therapy.
Yeah, I think the numbers in the current trial were probably too small for us to really take any meaningful takeaways from it. So Dan, you were one of the investigators on the phase 2 and phase 3 studies of acoramidis, and the phase 3 data was presented and published last year. Can you remind us about the ATTRibute-CM trial and its outcomes, please?
Yeah, so just to remind people of the ATTRibute-CM trial that was published at the beginning of this year. It was a randomized, double-blind, placebo-controlled trial of acoramidis, a new oral stabilizer for TTR, randomized 2-to-1, so twice as many people on treatment as placebo. And in this case, tafamidis was not allowed at baseline, probably the last placebo-controlled trial we'll see in this field. We used a complex win ratio, or Finkelstein-Schoenfeld analysis, with hierarchical assessment of all-cause mortality, CV hospitalization, NT-proBNP, and 6-minute walk test distance. And in that analysis, acoramidis compared to placebo was clearly successful. One of the things that's notable about it is that when we look at the tiebreakers, the points where we were able to make success, it was really on those first two, the hard endpoints of all-cause mortality and CV hospitalization. Now, when you look at the death signal, the mortality signal, we didn't quite reach statistical significance in 30 months. When we look at the biomarker data, just as in other therapies, we're able to show that with placebo, NT-proBNP certainly rises, and acoramidis far less. 6-minute walk test distance declined, but far more in the placebo arm than the acoramidis treatment arm. We looked at KCCQ, a standard measure of quality of life, and acoramidis again, curve separated early and continued to separate through 30 months. Another thing that we're exploring as a marker of efficacy is the ability of a stabilizer to raise the TTR level. And acoramidis potently raises your TTR level, and compared to placebo, of course, which remained fairly flat, we saw not only an increase, but a sustained increase in TTR levels. One of the things that people have asked for and we were able to show is the complex win ratio, and using ties and comparing each patient is kind of complicated. So we did a more traditional analysis and showed that earlier this year, but after the initial publication, a Kaplan-Meier survival analysis of acoramidis versus placebo, time to first event. And that was again, and again, we only looked at the top two markers, CV hospitalization and all-cause mortality. And in looking at those two, time to first event for those two, the curve separated at 3 months, so fairly early, and continued to separate over the course of 30 months. And from this, we take a number needed to treat to prevent death or heart failure hospitalization over 2.5 years of 7. So we're excited about that, and we achieved statistical significance.
Yeah, that's really kind of solid data coming out from these post-hoc analyses. So we've seen further data emerge this year. What's been the kind of most interesting data you've seen from these follow-up sub-studies?
Well, there was a lot at ESC at the end of the summer, and I'll talk about 3 different studies that some of my colleagues who were involved in the trial were able to show. I think another measure of quality of life is called the EQ5D5L measure, and that's really 2 things that people look at. 5 levels of response across 5 different dimensions, so you can be 1, 2, 3, 4, and 5 as a scale of how well you're doing with mobility, self-care, usual activities, pain and discomfort, anxiety, and depression. We showed an improvement there, and we also used a visual analog scale that extends from 0 to 100, 0 being the worst possible health and 100 being the best possible health. And what we showed is, compared to baseline, acoramidis showed a meaningful benefit in EQ5D5L visual analog scale of 10 points at 30 months. We've also looked at the serum levels of TTR, prealbumin is the other name for it, with acoramidis versus placebo. And as I mentioned previously, at 30 months, we were able to sustain that increased level. As we look at the probability of poor outcome, for every 5 milligram increase in the serum TTR level, the risk of death was reduced by 31% in the logistic model and by 26% in the Cox proportional hazard. We're eager to see this pan out, although we can't apply it for a silencer because it's the opposite effect. And then the last is the NT-proBNP levels. And for this, one of the things that we were able to show is a progressor index. And we followed it serially over the course of 30 months, and starting with 3 to 6 months, and 6 to 12 months, 15 to 18, 21 to 24, 27 to 30 months. And the change in your NT-proBNP level, comparing those on acoramidis versus placebo. And we saw a consistent improvement in NT-proBNP change in response to acoramidis versus placebo.
Yeah, really great to see all this just growing and growing data supporting all these different therapies for ATTR cardiomyopathy. So Dan, I'd ask you, can you give us a brief overview of the recent updates that are presented at the AHA?
Yeah, we're excited about 2 additional things. The first of which is something that Kevin Alexander is showing, that we know CV hospitalization is clearly a problem, and it's a poor marker for prognosis. And no surprise, if you're hospitalized for cardiovascular reasons, your likelihood of death is clearly higher. And in treatment with acoramidis, we're able to not only reduce CV hospitalizations, but that correlates with outcomes related to mortality. And this really, for the first time, we're able to show that the all-cause mortality signal that was not statistically significant at 30 months, when we get out to 36 months and then by 42 months, in both cases, were statistically significant, showing that early treatment, and that's the important thing, and just as Mariana said with the vutrisiran and HELIOS-B, the earlier you start treatment, the better it pays off in the long term. So once again, we've got statistical significance for acoramidis, and the earlier you start, the better you are.
Yeah, it's a great message, and I think we'll repeat it over and over again. So Mariana, your group does a lot of CMR, and you were part of the CMR sub-study for the acoramidis trial.
Absolutely. So the acoramidis trial was the first trial which had a formal CMR sub-study within the trial. And why CMR is so important in amyloid is because we can measure structure and function with probably a high accuracy and precision compared to echo. But it's really the information, the ability to inform about the tissue composition, which is really the key element here. And so within the acoramidis trial, there was a sub-study with the CMR and T1 mapping, and we used ECV mapping to track changes in amyloid load. And acoramidis was associated with a trend towards reduced extracellular volume from baseline compared with month 30. So ECV reduction of more or equal than 5% has been shown to indicate cardiac amyloid progression, and we know that that threshold actually correlates with a better mortality. So if you change your ECV of more than 5% at 6 months, we know that that correlates with a better prognosis, for example, in a yellow amyloidosis. And what we saw, which was really to me quite extraordinary in this trial is that there was 12% of the patients receiving acoramidis had actually cardiac amyloid regression at 30 months compared to placebo, where there were no patients having the cardiac amyloid regression. And that really, why is so important? Because it shows that if you deeply reduce the new amyloid production, then you allow the natural clearance to exceed the deposition, and so you manage to disrupt that dynamic between deposition and clearance, and you will see regression in some of the patients. And this was the first trial to show actually this proof of concept. If you deeply reduce the new amyloid production, which you do with acoramidis, which is a near complete stabilizer, you can actually have a proportion of the patients with cardiac amyloid regression.
Yeah, it's really great to see kind of what we've learned from light chain amyloidosis, AL amyloidosis over the years, where we were able to really stop that precursor protein, kind of now being reflected out in transthyretin cardiac amyloidosis. As you said, where either if we can knock down or deeply stabilize the protein, we are giving some patients the kind of opportunity to show improvement in these parameters. So I spoke about tafamidis at the very start of this. This has been approved since 2019 as a stabilizer in transthyretin cardiomyopathy. And there's been further long-term data published over many years, and this year is no exception. So I'll briefly recap some of the findings. So at the ISA and then a subsequent publication, we looked at tafamidis efficacy in octogenarians, so those patients enrolled in the original trial who were over 80. Now, not a large number of patients, but pretty significant cohort, and I think a lot of the cohort of patients that we see in clinical practice. There wasn't a clear benefit for CV hospitalizations, but the trend was there for mortality. I think somewhat limited by the fact it was small numbers, and also we're talking about patients into their 80s, where there's probably a lot of competing risk. And it was really nice to see that patients benefit from tafamidis therapy over 80 as well. And mainly on those kind of functional and quality of life metrics, such as 6-minute walk and KCCQ questionnaire. As well, LV ejection fraction is something that we don't talk about as much in amyloidosis, because we know that it doesn't really help parse out our patients too well if their EF is below or above 50%, like it does in other heart failure therapeutic trials. But it was still kind of very encouraging to see in this sub-analysis of the ATTR study and long-term extension that it really doesn't matter if a patient has an EF above or below 50%, they'll still benefit from drug. So we have all these trials, and one of the key differences in the trials is the patient populations. And I kind of would like to hear your thoughts and for you to elaborate on this, please, Dan.
Isn't it amazing that we now can talk about like which drug to use as opposed to, you know, here's the only drug or there is no drug. So I think it's a new thing for us in the amyloid field to be able to say, well, how do we compare these drugs? And can we say this one is better than that one? I think for me, the most important thing to take away is those cross-trial comparisons, which are very tempting, are just not valid. I'll use an example. If we take the ATTRibute-CM trial, just published, and the ATTRACT study that was published now several years ago, if you look at the treatment arm in ATTRACT, that's tafamidis, versus the placebo arm in our ATTRibute-CM trial, the placebo arm did better. And I'm certainly not saying that our placebo is better than tafamidis, just that those are very different time courses, different patients. We've gotten to being able to diagnose amyloid at an earlier stage, and patients have a better prognosis when we find them earlier. So I think the main takeaway for me is it's very hard to compare different drugs in these different trials.
Yeah, and I couldn't agree more. And I think we're achieving what you were kind of pointing out, the importance of early diagnosis. And we're seeing that play out in these trials, that the patients who are diagnosed earlier are doing better. So Mariana, I'd like to ask you your thoughts on comparing and contrasting these pivotal trials.
I mean, I have to say I have absolutely nothing to add compared to what Dan said. I completely agree on the fact that we cannot compare the different clinical trials, and the patient population have evolved so much over the years, and we know that patients with the same characteristics diagnosed 10 years ago is not wouldn't have the same prognosis of a patient diagnosed today, because we have been able, with the incredible advance in diagnostic, to diagnose patients earlier and earlier. So from the time of diagnosis, they actually do much better. So we cannot compare the clinical trials, and very similar to what Dan said, I'm just actually really glad that we can think about different drugs with different mode of administration, different mechanism of action, and actually having the choice for patients to say, okay, here are all the available options, which one would you prefer? Because there will be some patients that prefer to take a pill and other subcutaneous injection, and so having the offer and for patients and the choice is actually quite incredible.
Yeah, and I think also being able to tell patients their prognosis is so much better than what was published 5-10 years ago. So we're at the AHA, we've had an exciting meeting, and I'd love you to discuss some of the breaking data from the AHA, Mariana.
Yes, it was a very exciting day because they presented the results of the NEXT-Z trial, which was a phase 1 ongoing trial in patients with ATTR-CM. I mean, what's unique at that approach is that it's one single infusion of a genome editing therapy. And so with one single infusion, we go and edit permanently the DNA in the liver cells. And what we do, we introduce a precise cleavage in the TTR gene sequence that leads to permanent inactivation of the production of transthyretin in the long term. 5 years ago, we would have never thought that this was going to be possible, and now we give an infusion to patients for 4 hours and the DNA is permanently modified, and the protein production, both the wild type form and the variant form, is inactivated. And what was nice to see in this trial of 36 patients with ATTR cardiomyopathy was that there was disease stabilization and actually improvement in some of the parameters across a wide range of markers, which included blood biomarkers, NT-proBNP and troponin, functional capacity measure with a 6-minute walking test and cardiopulmonary exercise test, and imaging, echocardiography, and cardiac MRI to T1 mapping. So it amazes me how a deep phenotyping in a 36 patient trial can give so much information and really show how a rapid, durable and permanent knockdown can lead in such a small population with very severe disease, because one of the key findings was that the population was very severe. 50% of the patients had NYHA function class 3, for example.
Yeah, I think we're all really excited to see the phase 3 study and the cardiovascular outcomes, because that's also like key to knowing how efficacious these therapies are, but very promising data so far. So let's move on and discuss what the data means for practice and how the landscape will evolve. So Dan, it's a tricky question, but how will the likely future approvals of emerging agents impact clinical practice?
Well, I think first of all, I remember the days when I would talk to my colleagues and say, you really have to diagnose amyloid, and they would say, why? We can't treat it. And those days are gone. So I'm excited that we can now diagnose and treat early and prevent disease progression, or as Mariana said, potentially reverse disease, which is exciting. I think choosing among the drugs is, I would love to think that I'm the one that's going to make that decision, but we do that shared with our patients, and then of course the healthcare payer will have a big say in it too. So it's new territory right now for wild-type TTR amyloid. We have one drug, and I look forward to having more than that one option.
Yeah, for sure. It'll be great to have options, and I think unfortunately cost is one of the limiting factors for all these novel therapies. I don't know what your opinions are on it, Mariana.
I mean, I absolutely agree with Dan. I mean, the first decision will be based on cost, on what we can have. In certain countries, we're going to have access to certain but not others medications. I am a big supporter of combination therapy, but combination therapy, the biggest hurdle is going to be actually the cost. In the same, combining two very expensive drugs is not going to be possible for the vast majority of patients. And again, as Dan mentioned, it's a shared decision with the patient, because certain patients will prefer a pill, others will prefer a 3-monthly, 4 times a year subcutaneous injection. So it's really the discussion with the patients about the mechanism of action, the route of administration, and the cost and availability in that specific country that will help us to actually make a decision about which treatment is the right treatment for the patient that we have in front in the clinic. Absolutely.
And you mentioned there, you kind of are a believer in combination therapy. So I'm going to ask you to elaborate on that a little bit for us.
I mean, we know from other types of amyloid, AL and AA, that the greater the knockdown is associated with better outcome. So in AL amyloidosis, we try to achieve 100% knockdown in the amyloid precursor protein in all patients, or at least 90%. And the pathophysiological reasons why I believe in combination, in the possibility of combination therapy, is because if we, for example, knock down the production of 80% with a silencer, and then we stabilize the protein, we are achieving virtually 100% knockdown. So there are the pathophysiological bases for which combination therapy could be really the future in our patients. And that is also supported by the HELIOS-B trial, where we see a potential added benefit of vutrisiran on top of the tafamidis, because we couldn't see attenuation of the treatment effect in patients on and off the tafamidis. So we don't have the definite answer yet. Maybe the definite answer will come in the future with the TTR-Transform trials. We have in that trial enough numbers for hopefully to be powered to show an effect in patients on tafamidis. But I guess at present there are all the premises to believe that combination therapy could be a future for our patients.
Yeah, that's a great point. The ongoing trial of eplontersen CardioTransform with much larger numbers may help answer this question. But Dan, I'd love to get your opinion on combination therapy.
Well, one of the things that's surprising is we haven't talked much about toxicity. And why is that? Because each of these drugs is really well tolerated. There isn't much toxicity other than the one that Mariana mentioned, which is the financial toxicity. So I think that's, for me, the challenge, and I'd like to see more proof. As Mariana said, there is potential, and I agree, and I think the science is amazing to be able to use dual therapy, but I'd love to see more quantitative or clinical outcome data that shows that that's the best approach.
Yeah, I think that's always the key to how we practice. We need to see those kind of hard endpoints clearly indicating benefits than kind of just going on potential trends and hypotheses. So it's been a very exciting year, but I'd like to ask you both, what kind of excites you about the upcoming studies and sub-analyses? So I'd start with you, Mariana.
I mean, there are so many things in the year to come, so it's difficult to point out one that I'm excited about. There is going to be the TTR-Transform study, the largest study done by far in patients with ATTR cardiomyopathy. So the number of sub-analyses that we can do in that trial is going to be incredible. But also all the sub-analysis that is now coming out in the acoramidis trial, in the HELIOS-B trial. So there is, I think, a lot to come, and it's very difficult to say just a few things that I'm excited about, because I think there are going to be many.
Yeah, and Dan.
Yeah. And one more area that Mariana is leading the field in is the antibodies that remove TTR amyloid, and that has enormous potential too. I'm excited about those clinical trials.
Yeah, I think we've seen some very exciting early data about antibodies for ATTR cardiomyopathy, which could be a real game changer in the field. So Mariana and Daniel, thank you for this great discussion. It's been really fun doing this recap. I've learned a lot. And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.